Today we have the
And
pleasure.
we're live in 5, 4, 3, 2, 1.
But as you can see, we have a new introductory video. Today we have the great pleasure to have with us Dr. Nestor Gonzalez. He's a professor of neurosurgery and director of the Neurovascular Laboratory at Cedars-Sinai Medical Center in LA. Dr. Nestor Gonzalez completed a unique training, 2 residencies, the first in diagnostic radiology in Colombia and then neurosurgery at the university at UCLA. He then completed a vascular and endovascular fellowship at UCLA and a Master of Science in Clinical and Translational Research. He has been faculty of the Departments of Neurosurgery, Radiology, and Computational Biology at UCLA, and is currently faculty at the Departments of Neurosurgery and Pediatrics at Cedars-Sinai. He's an extremely prolific researcher with more than 200 publications, has received several grants from the NIH and the American Heart Association, including 3 National Science Innovation Awards and the National Transformational Science Award. Dr. Gonzalez is the chair of the Stroke Neurovascular Intervention Science Committee of the AHA and serves in the NIH Scientific Review Committee and as an international advisor for the Karolinska Institute in Sweden. Professor Gonzalez, there is so much to say about you, and we are really grateful that you are here with us. Your topic is extremely interesting for us, and please go ahead and share your screen.
Thank you. It's a pleasure to be here, and thank you, Matthias, for that general introduction. Let me check with you my screen here. And let's jump into it. I'm going to be talking today about a subject that is very dear to my heart because I have been working for a long time on it. And because I think it presents a different alternative for the management of a complex problem that is intracranial atherosclerosis. And we're going to be talking about a surgical technique that many institutions have been applying already for patients with moyamoya. Some of them have been applying for patients with intracranial atherosclerosis, and that I think has shown a lot of promise and make it a very interesting option of treatment for the patients with this difficult condition. I don't have any commercial interest to disclose. My research, as you mentioned, is being funded by the NIH and the American Heart Association. So the main issue that we have is that intracranial atherosclerosis is actually a very serious problem, and it's probably more serious than we have realized in the past. The traditional learning that we have is that stroke is commonly produced by embolic origins, such as carotid disease or atrial fibrillation. But the truth is that intracranial atherosclerosis is a common form of stroke. At least 10% of all the strokes that occur in the United States are produced by intracranial atherosclerosis, and that situation is even more dramatic around the globe because intracranial atherosclerosis has associations with different races that increase that risk, and more than 20% of all the ischemic strokes around the world are produced by this condition. As this data from the North Manhattan study published in Circulation in 2006 shows, the rate of a stroke associated with intracranial atherosclerosis affects disproportionately subjects from Black race, Hispanics, and Asians, being as much as 29% among Blacks and 26% among Asians. And this has been shown in several studies. And the significance of the problem is not only in the magnitude of strokes that can produce in these populations, but also in the resilience of the disease. Intracranial atherosclerosis is difficult to treat, and even with the best medical managements that we have now, the rates of stroke remain between 15 and 37%, which is quite discouraging. I have put this big title from the paper that was published in Neurology more than 16 years ago that did an evaluation of the natural history of patients with intracranial atherosclerosis. And at that time, the 2-year recurrence rate of ischemic events in the patients that have presented with an ischemic stroke due to intracranial atherosclerosis was around 38.2%. And you will think that after 16 years, the things should have improved. We have definitively better medical management, and clearly there has been some improvements. But as I'm going to show you, the data actually shows that the advancement has been really, really limited, and we need better alternatives of treatment for this condition. The main source of interest in research for the management of intracranial atherosclerosis have been divided in both the medical management, almost as a consequence of investigating atherosclerosis for coronary artery disease, and in the potential application of techniques that have been shown to be useful in the heart, such as angioplasty and stenting. So several clinical trials, three of which have been published and one that is going to be published pretty soon in JAMA, have addressed the issue of the use of angioplasty and stenting compared with medical management for the management of patients with intracranial atherosclerosis. And one of the main advancements that we have to recognize is that we are aware that the management of the medical associated conditions is essential, and that aggressive medical management of the risk factors of a stroke play a very important role in protecting these patients. And this is important because before we get into the results of those studies and why it's necessary to have an alternative like the one that I'm going to present today, we need to understand the complexities of the mechanisms involved in producing strokes in patients with intracranial atherosclerosis. One of them is the one that results due to a narrowing of a vessel and the characteristics of the cerebral vasculature that is terminal in nature. That means the majority of our collaterals are located on the circle of Willis, and even though we have peripheral collaterals, they vary a lot, and as we age, they become less functional. Then the narrowing of an artery may very easily end up producing hypoperfusion, or reduction in the amount of blood that can reach the cerebral tissue. A second mechanism that is frequently involved is the disarrangement of the plaque that ends up producing artery-to-artery embolisms. There is also the possibility of the creation of thrombus or clot in the segment where the artery narrowing is located, which then produces in situ thrombosis. And this, besides the formation of the plaque, can also affect the origin of small vessels that originate from that segment, particularly in the anterior circulation of the middle cerebral artery or in the posterior circulation from the vascular artery, producing perforators occlusions that end up producing basal ganglia strokes. Now, most likely, there is a combination of mechanisms, and it has been clearly shown by the studies of Kaplan and others that when somebody suffers even an embolic stroke associated with intracranial atherosclerosis, it is not usually an isolated phenomenon of artery-to-artery embolism, but the hypoperfusion plays an important role on that. And that's why many of the embolic strokes accumulate in the hypoperfused areas that are known as border zone or watershed strokes. Now, the advances that has been achieved with the clinical trials are mainly based on the ability to correct the in situ thrombosis and the perforators occlusion by using statins, by using antiplatelet agents. However, the very important component of hypoperfusion is not being addressed by the medical management, and then to some extent, the artery-to-artery embolism is not addressed either because of that mechanism that I explained. So the best medical management that we have addresses half of the problem, but not the complete problem. And then the results of clinical trials that have been trying to use angioplasty and stenting come to add the disconcert with this problem that is so difficult to treat, because unfortunately they have failed to show a significant benefit in the management of these patients. In fact, in the largest and best organized NIH NINDS clinical trial that was Sampris, the rate of a stroke in the interventional arm that received medical management simultaneously with angioplasty and stenting was extremely high, was 21%, while the risk of stroke in the medical management was 15%, which basically has dictated what is considered today the standard management of this condition, that is medical management. There is several other studies that we will review briefly that have shown similar results. The VISIT randomized clinical trial tried to use a different stent, this one balloon-mounted stent, and unfortunately, the results for the interventional arm were not that positive. You see on the right, the Kaplan-Meier curve that shows that the cumulative event-free survival was higher in the medical group, basically with higher rates of recurrent stroke in the stent group, almost replicating completely the data from samples. And additional trials like the Miao trial in China have shown that, again, there was no benefit with angioplasty and stenting with rates of stroke of close to 20%, which were still nominally higher than in the medical group. This clinical trial was not concluded because of the results of samples and VISIT. There is another trials coming on the pipeline after the development of different selection criteria for angioplasty and stenting that will be published soon, and we'll see how the results are, but unfortunately they are suffering of the same conditions, that the benefit doesn't seem to be there for angioplasty and stenting. So part of the issue is that despite these new attempts to get a reduction in the number of complications, the most recent studies that have addressed the possibility of using angioplasty and stenting have several limitations in their design. There is a lot of assessment bias. The majority have been single-arm, self-reported studies, and the selection has a problem, that is that have selected patients that are really not those at the highest risk, and that's why it's very important that we get a comparison with the medical management to see if there is any really benefit in doing the angioplasty and stenting. And doing angioplasty and stenting, as I'm going to discuss later, has some issues because technically you have to go through a plaque, you may disrupt the plaque, and the vessels of the brain are clearly different than the vessels in the coronary arteries and in other vascular beds, which may add to the complexity of using that technique. So far, the management that we have for the treatment of patients with intracranial atherosclerosis is basically medical treatment that is focused in trying to change those factors that we consider modifiable risk factors: hypertension, hyperlipidemia, diabetes, obesity, and smoking, things that we can control with changes in lifestyle and, of course, with medications. However, some of the non-modifiable risk factors are still very problematic. We know that atherosclerosis occurs more frequently in elderly patients. That is a problem. We know that patients that are of Hispanic, Black, or Asian ethnicities and race have a higher risk of having strokes. There is lower risk for females that are younger than 60, but then equal the risk, and in some instances may become even more problematic. And those things we cannot change besides the anatomy of the vessels and the availability of collaterals. But the proposed treatment that we have been working on, that I'm going to present today, actually address one of those factors. One factor that we have been considering so far is non-modifiable, that is the risk of the change of risk by modifying collaterals. And this is important because if we take the largest and best design of these trials that tested angioplasty, stenting, and medical management, and we concentrate in the medical arm group, the one that did very well or did well, there is subgroups of those patients that are at higher risk of having a stroke, even with the best medical management that we have available. Patients that are older than 60, patients that have had an old stroke in the territory that is being affected, and patients with stenosis of the carotid artery have all of them very high risk. And in this sense, the authors of samples have published several post hoc analyses, and one of the most interesting is the one that emphasizes the mechanism of hypoperfusion that I mentioned initially. They conducted a post hoc analysis in which the patients in the medical arm and in the interventional arm with different types of territorial strokes were compared. And the rate of failure of the good working arm, that was the medical arm, in patients that have borders on strokes is extremely high, it's 37%. And for those patients that have cortical strokes, many of which are associated with this mechanism that I explained of artery-to-artery embolisms associated with hypoperfusion, still the rate of a stroke is 30%, which means that if you remember those data that I present from the 2006 natural history study and this paper that was published in 2019, in all those 13 years, with all the advances and efforts that we have done, we have really not been able to modify the significant high risk of recurrence of patients with intracranial atherosclerosis. And the common factor is that the medical management addresses some of these important contributing factors, but it doesn't address the issue of hypoperfusion. And that's why borders on strokes and those artery-to-artery embolisms associated with the deposit of some of these embolus in the borders on areas maintain very high rates of recurrent stroke. Now, what can we do for that? Well, in the surgical realm, we have not been so far much successful to an extent. I'm going to show you some data that can give some hope for the treatment of surgery, particularly lessons that we have learned with the application of direct bypasses. And as most likely many of you know, there are two different forms of create bypasses in the intracranial circulation. The direct bypass, in which we basically resect an artery, usually a superficial temporal artery, or use a graft, and connect it directly to one of the middle cerebral artery branches or other target vessel. And the indirect bypasses, that is the one that I'm going to concentrate more today, in which the artery is not a section, but is just isolated from the skin and then rerouted. And there are some modifications that can be done around this with the use of muscle or other forms of flaps to try to bring vascularized tissue to the surface of the brain. But in essence, in the direct bypass, there is an immediate kind of solution by putting blood flow into the intracranial circulation. In the indirect bypass, there is a little bit more delay, but not much, as I'm going to show you, response in which the vessels on their own can produce new vasculature that brings some collaterals to the brain. And this is actually interesting because there are several animal studies that have shown that while the endothelial cells of the vessels of the brain cannot on their own produce significant collaterals due mainly to the significant specialization that the cerebral vessels have that have made them lose some of their ability to create more free angiogenesis. Vessels and tissues from other locations like the superficial temporal artery or the temporalis muscle don't have those limitations. And when they are exposed to a hypoxic environment, they readily produce a number of vessels that end up producing numerous bypasses. And this response, even though it's ameliorated by age, is not suppressed by age and is not exclusive of pediatric patients. These techniques of indirect bypass have been extensively used in patients with moya-moya disease, particularly in pediatric patients. And for many years, we have had these rational thoughts that probably they would not be that effective in adults because the ability to create vessels is less in an adult than in a kid, or that probably they would not work in conditions different than moya-moya due to the significant angiogenic component that the moya-moya disease has. But those were actually logical assumptions, but not based on reality, as I'm going to show you based on the data. Now, to go back to the point of the direct bypass, we tried this too, as you well know. We have done two large clinical trials, the EC-IC bypass trial and then the COST trial, the first one in the middle of the 80s and the last one at the beginning of the 21st century. And both of them show significantly disappointing results, very, very similar one to each other. Kind of one of the few differences was in the EC-IC bypass trial, we used the technique for patients also with stenosis, and that group did actually worse than patients with occlusion. Part of that due to the fact that when you put a direct bypass in a patient that has an stenotic vessel, there may be a chance of competitive flow. And Isamawat did several analyses showing that that was one of the main mechanisms of strokes. And in my lab, we also have shown that when the stenosis is close to 90%, the flow that is introduced by a superficial temporal artery may produce competitive flow in the proximal segments, and in the M1, where numerous lenticular striated vessels are originated, that flow can become virtually zero, which is, of course, a condition that can produce thrombosis in situ and may explain the high number of lenticular striated strokes that was seen in the EC-IC bypass trial. To try to correct for that, in the COAST trial, we didn't use patients with stenosis to be included, but only patients with occlusion were included. But the results were very similar, as you can see in the Kaplan-Meier curves from each study. The most important thing to look at that, particularly in the data from the COAST trial, is that at the end, those curves cross, which just point to the fact that they are not significantly different, but also show that in the long term, the patients with the EC-IC bypass trial have some benefit. The problem starts in the first 30 days when you see that compression of cases where rapidly the surgical group become worse than the medical group. And this is because of the rates of perioperative strokes in those populations, which was around 12% in the COAST trial and around 15% in the EC-IC bypass trial. So if we can come with a solution to that problem of the perioperative stroke, the bypasses in the long term may work. In fact, the problem of this trial was not that the bypass wasn't working. 95% of the bypasses in both trials were open at some point. The problem is that we were not able to catch up in the long term with the short-term complications of doing a relatively complex surgery. So why to think about indirect bypasses? The logic is because of that, because indirect bypasses are easier surgical techniques, and because they have several advantages when compared with both direct bypass and with angioplasty and stenting. Indirect bypasses are less technically demanding, so there is a lower chance of having complications during the procedure because it's relatively simple. There is no need to do any temporary occlusion of vessels like is necessary during the direct bypass to connect to a middle cerebral artery. And even though in good hands, you may be able to do a complete suture in 6 to 10 minutes, in many cases, that is not the case, and you have to do it, and it takes a little bit longer. And even if it is for only a few minutes, the time of ischemia in the vessel that is already critically bringing an amount of blood that is reduced to the brain may induce strokes in these patients. The additional advantages is that when you do direct bypasses, you avoid some of the complications that we have seen in patients with direct bypasses and that are common and can be very serious. There is no brain swelling. There is very almost unlikely chances of having hemorrhage because there is not going to be a new flow introduced to territories that are not used to have it, and avoids the competition of flow that I explained a few minutes ago. So there are some logic to think that maybe an indirect bypass can be beneficial compared with a direct bypass. There are also some advantages with angioplasty and stenting. You don't have to manipulate with wires or stent a disease segment with the risk of either breaking the plaque, producing lenticular striated strokes, dissecting the vessel, or producing embolisms. And besides that, you're also not changing the conditions of perfusion of the brain suddenly, which then may be important to reduce the risk of hyperperfusion. Now, before we get into an important question, that is, this sounds very good, but indirect bypass doesn't produce a change of flow right away, and what is the timing of those vessels to grow that I will address, I want to show you a little bit of additional points that have to go to that factor of trying to reduce the risk of a stroke as much as we can when we do these surgeries. As I mentioned, indirect bypasses are simple, but I want to show a couple of technical things that we have learned. And EDASs or indirect bypasses can be done in different formats. And I'm not going to advocate that there's only one way to do it, but I'm going to show you what we do and what we have been testing in patients with intracranial atherosclerosis that has been effective and that, if anything, has contributed to reduce significantly our rates of perioperative stroke compared with the EC-IC bypass trial and with the COST trial. We like to mark the artery with the Doppler because I like to do the dissection of the artery directly on top of it, just like I would do for a regular direct bypass. Using the ultrasound allows me to know exactly where the vessel is, allows me to get an idea of the flow that I will be getting through that vessel. Then we position the patient with a little inclination of the head. We monitor these patients very strictly with EEG monitoring because it's important that we have that information. We can titrate a little bit the blood pressure if we notice that there is a reduction in the amplitude of the waves in the EEG. And one important part is this last third picture, that is that we have actually always monitors in which we can see the vitals of the patient. As I'm going to discuss with you, we take a lot of care in the preoperative evaluation to determine which are the levels of blood pressure in which these patients don't have any symptoms. And we strictly manage the blood pressure to maintain them in those levels. And sometimes it's important to help the anesthesiologist not to get into the automatic pilot mood and be sure that during the surgery, the perfusion is maintained. In several studies of the effects of anesthesia in cerebrovascular problems, it has been shown that excessive variations in blood pressure can cause problems. If it is too low, it may get to strokes. And it's important that we help them because we have that in mind. Also because the general idea of doing these vascular interventions is different than the principles that they may have learned for any neurosurgical procedure. We will get into detail into that, but basically in vascular surgery, we don't do many of the things that you will do to resect a tumor, for example, which can increase the risk of a stroke. But we will discuss that in detail. Let me get into the surgical technique, and I'm going to play a video in which basically shows the main steps. So we do a very small incision, and I like to dissect the artery under the microscope because that allows me to see every little vessel disconnected safely, reducing the risk of having hemorrhages. We advance little by little with superficial incisions until we see the dermis. Then we dissect bluntly with the mosquito on top of the artery, and then sharply, either with a Colorado needle or with micropinch scissors in both the surface of the vessel and in its size. Then we separate the artery, and if we encounter a bleeding, like in this case, we use very low voltage coagulation. We use only like 25 watts or so to prevent damage of the artery, and also to prevent to burn excessively the collateral branches that at the end are the ones that are going to be producing the collaterals in the indirect bypass. Once we have the artery separated, I move it to the side, and I try to preserve also as much as possible the meningeal branches once I have constructed a craniotomy. We normally don't do very large craniotomies for these patients. It's usually an oval craniotomy. And respecting the branches of the meningeal artery, we open the dura. There are different techniques that you can use for the dura management, but because we don't give mannitol to these patients, I have found very useful to rapidly open the arachnoid and start draining a little bit of CSF, which immediately relaxes the brain without the need to use mannitol. Some people propose to fold the dura mater. The way I like to do it is I like to peel the dura mater like it was one of those packages with cheese strings that can open in both sides. The dura has several layers, and expose a little bit the more vascularized inner surface of the dura. I actually send these tissues to pathology to see if there's an abnormality. I haven't found anything so far. And then we immobilize the artery, and these sutures don't have the purpose of preventing CSF leak. It's not a watertight suture. It's just to prevent the mobilization of the artery, because the initial vessels that are going to form by angiogenesis are very delicate, and the pulsation of the superficial temporal artery may actually break those vessels. So we suture it with an 8/0 or a 9/0 nylon to the dura mater to prevent the horizontal displacement of the artery. And we do that with all the leaves of the artery. And as you're gonna see after this quick last stitch, we put some sponges on top of collagen. That's a little bit of the flow seal to prevent the hemostasis. And then we create a little compression down, which is gonna reduce the vertical displacement of the superficial temporal artery, put back the bone flap, having large buttholes to allow the artery to come in and out without compression. And then we close, and the closure is done in a very careful manner to try to close all the galea. I normally like to pass all the stitches without tying them because when you dissect the superficial temporal artery, you take a little bit of the galea, so the galea tries to retract. And if we close as we normally do, a craniotomy just going by tying as we pass the stitches, the last few of them may be difficult to see, and you may not be getting galea. So I like to pass all the stitches, and once all of them are passed, then tie them in that way. I'm sure that every single stitch got a little bit of galea, and that has helped us to reduce the risk of dehiscences of the wound. So this slide is very important because one of the main lessons that we have learned, besides being careful with the surgery and as I showed you, trying to do it as clean as possible, is that we do things that are different to try to reduce the risk of a stroke of these patients. And they're different to the traditional way anesthesiologists may be used to give anesthesia to neurosurgical patients. We want to reduce the risk of thromboembolic events. Because of that, we prefer not to suspend the antiplatelets, and we do the surgery while the patient is taking at least aspirin 325 milligrams every day. We have few cases of patients with allergy to aspirin, and we have done the surgery with Plavix. A few years ago, this was considered more controversial, but I think today many surgeons are used to do operations with aspirin because of the cardiac risk, and is perfectly well done as long as you are meticulous with the hemostasis to avoid the hemorrhages and the hemorrhagic complications. So you just need to take your time. Now, with this hemostasis, as I mentioned, I use very low power to try to avoid charcoaling and causing too much scar in the stumps of the little collateral branches of the STA, because those are the vessels that are going to end up producing the new vessels. So I use very restricted, very fine tip jugular bipolars to do that. Now, to maintain the cerebral perfusion in patients that may have hypoperfusion, we ask the patients to maintain a diary of the blood pressure before the surgery at home. And based on that data, we maintain between the average level to around 20% above during the surgery. This is strictly managed. So the patients have an A-line, and we talk with the anesthesiologist to be sure that they don't allow them to be hypotensive at any time, including the induction. So in many instances, it's important to put the A-line before the induction of the anesthesia to be sure that during that critical period, there is not hypotension. We also remind them that we don't need hyperventilation, and that there's still, we rarely really use hyperventilation even in cases of trauma, because as you know, that produces vasoconstriction. Is only a transient measure that may help with intracranial pressure, but definitely for patients with EDAs, we don't need to have hyperventilation. We try to prevent dehydration. So because the patients have been MPO since the night before, we usually load them with boluses of fluids at the beginning of the surgery, even from the moment that they come to the preoperative area. And we don't give them mannitol. That's why it becomes important to use dissection of the arachnoid to release some of the CSF, because the brain tends to be a little bit tense at the beginning. But with some drainage of CSF, usually that problem is resolved. At the end of the surgery, we want the fluid balance to be positive, never negative, at least even, but preferably to be up to 2 liters. And because the process of angiogenesis is induced by the inflammation that the surgery and the peeling of the dura and these things cause, we prefer to not to use steroids. The anesthesiologist sometimes like to give a little bit for nausea, and that's okay, but we don't use the large doses that we may use typically in other intracranial procedures. Then the patients are closely monitored in the ICU, where we maintain the same blood pressure parameters, and we strictly manage them with drips. Is kind of complicated to allow the use of PRN medications, because if a patient is a little bit hypertensive, they may give a large dose of, let's say, labetalol or another agent that they cannot control, and then next thing you know, the patient may be hypotensive, and that can cause a stroke. So I prefer to have them with drips, either of antihypertensive or pressors, to maintain the level exactly where we want, and we can titrate it more precisely, about avoiding to go either above or below. We maintain that positive fluid balance, and we don't use steroids. We continue the aspirin with no interruption, and for now, we have been doing electively the use of Plavix to follow the guidelines of medical management, usually after 10 to 15 days from the operation, and for only 3 months. And we also give them seizure prophylaxis, because the irritation that the surgery can produce may increase slightly the risk of seizures. Our nursing staff is trained to do detailed examinations to detect if the patient has any symptoms of TIA that usually can be managed just by putting the head of the bed down, increasing the IV fluids, increasing the blood pressure, and the majority of patients don't end up having significant strokes with that. If they don't improve with these measures, then we treat them like a code brain or code stroke, take them to angio, sometimes treat them for vasospasm if that is an issue, or do what we can is, of course, in patients with atherosclerosis is limited the possibilities of doing thrombectomies, but in some cases, if it is necessary, it can be done according to the general standards of management. So, based on these steps that we have taken to try to reduce the risk of the surgery, we have developed a pipeline of development, and we are about to start the phase 3, that is the RCS leading pivotal trial. And I'm going to present the data in support of the use of this technique, and how and why we think that this can be a very good alternative to the management of patients with intracranial atherosclerosis. We conducted first a pilot study, that was the EDAS pilot study, that included 36 patients. We recently finished the RCS-PC trial, that was a phase 2 clinical trial with 52 patients. And now we are planning the large randomized clinical trial, the RCS leading pivotal study, with 516 patients. In our first phase in the pivotal study, the main question that we have was, okay, I heard all the advantages that potentially EDAS may have compared with direct bypasses, but what about the timing of revascularization? How soon the patients really will benefit from this? Do we have to wait months for the new vessels to form? So we wanted to address that, because clinically, for many of you, this also may be the practice. We do angiograms or CT angiograms or perfusion studies around 6 months from the surgery, but that is a lot of late time. How these can be monitored. So in this pilot study, we look at the clinical outcomes of the patients, the perioperative rates of a stroke, but we also look at angiographies that were done within 1 month of the surgery, many of them at 2 weeks, and many of them at least at 4 weeks. And the results were very encouraging. The perioperative rate of a stroke was very low. We were able to maintain it below 1%, which is excellent. Of course, this is a limited population, but it's promising, because that one is already looking better than what we got with direct bypasses. And that was the main goal of doing all this fussiness about the medical management and the anesthesia management. The stroke-free survival at 2 years was also excellent, was 94.3%. Again, very promising. And kind of the most interesting thing was to do these early angiograms. In the subpopulation of patients that got early angiograms, all of them at 4 weeks have already some form of neovascularization, at least moderate to extensive new vessels forming. And this was not really we define any significant effect, but of course there is a small group, but generally happens in patients of all ages, and the majority of these patients were not young. So this was encouraging because it shows that the vessels actually start growing soon. And this has been supported by several studies that have been more recently published in both animal models of EDS and clinical studies of EDS. On the left, you see some of the histology analysis of the studies of Nakamura in uroencephalic miniature pigs, in which they have developed a model of indirect revascularization using EMAS or encephalomyosin angiosis. And basically, they have shown that 4 weeks after synangiosis, in angiography and in histological examinations, there are patent anastomosis between the external carotid artery and the cortical arteries. These, as you can imagine, are models that are not specific of moyamoya. They were not doing any to induce angiogenesis, except producing ischemia in that territory. So it is ischemia and hypoxia itself, the one that induces this vessel growth, and they were able to form vessels. More interestingly is the study on the right. There is a clinical study of both pediatric and adult patients with moyamoya disease. And in this study by Ishii, where they measure the MR perfusion and the mean transit time in the patients along the time post-revascularization. And what you can see in this graphic is that there was statistically significant improvements in the mean transit time starting between day 15 and up to the 180 days or so. So after the 180 days, there was kind of an stabilization that is already quite improved the mean transit time, but the effects of the revascularization start being seen between 15 and 30 days. And that is also clinically what we have noticed in this and the other studies that we have performed. Patients that have intracranial atherosclerosis that were symptomatic when we did the surgery, we maintain the blood pressure a bit high, we hydrate them very well. They may have occasional TIAs, but their symptoms tend to resolve around 3 weeks to 4 weeks from the time of surgery, which is very good. And that resolves the only concern that I really had of EDS being effective for these patients, that is how soon can that effectiveness happen? And it seems that it's around 2 to 3 weeks. Based on these results, more recently, we conducted a phase 2 study. This was an objective performance criterion trial in which we also plan to do a comparison with patients that were selected by propensity score matching from both samples and cause, because we included patients with occlusion. In general, basically, we selected patients that have the same inclusion criteria that they have for samples, with only one exception, is that we included patients with occlusion. And for that reason, we selected a control group from the COS trial that have intracranial atherosclerosis. In the COS, those patients were getting angiography, so we could tell if they have intracranial atherosclerosis. And this is a phase 2 study, so it was powered to detect a difference and maintain a threshold that will be an objective performance criterion of 10% below the rate of strokes in the medical arm of samples. This being a phase 2 was powered to have to detect an alpha of 0.1. And the rate of a stroke that we have at the end of the follow-up, that was, well, we followed them for 2 years, but the measure was done at 1 year after surgery, including the perioperative stroke and the cumulative risk of a stroke at 1 year was 9.6% stroke and death. Purely stroke was 7.7%. The deaths didn't occur by neurological reasons, but it happened due to cardiac problems in one patient. But the rate of a stroke reached that level of less than 10% that we have proposed as an objective performance criterion, which is a reduction of 50% of the risk of a stroke in the equivalent group of patients in samples. When we added an analysis with the propensity score matching, including patients also with occlusion, we noticed that that was being the case again, and that the study showed a significant reduction in the primary endpoint at 700 days, that was the end follow-up of these individuals, improve compared with the intensive medical management. And in this table, it's important to see that the groups were very homogeneous, both in the surgical arm and in the medical arm. And if anything, there was higher risk of strokes, higher risk factors for stroke in the surgical arm, with more patients with diabetes, more patients with previous stroke, which would basically favor that the medical arm should have been done better, but it didn't. The surgical arm did better with EVAs because we were able to reduce, as you can see in this graphic, at the beginning, the perioperative rate of stroke to keep it below 10%. In the last follow-up, 86.5% of patients were functionally independent, which is also very promising. And almost 90% of the patients completing angiographies at 6 months. This time we didn't do the early angiographies. We have done that already before in the pilot study. And the majority of them show good levels of neovascularization, as is shown in this slide. Then, based on the report that the post-hoc analysis of samples had shown of patients with borders on stroke, we also look at our population of patients with borders on stroke. And for those patients that presented with borders on stroke, we were able to reduce the rate of a stroke from 37% in the medical arm to 11% in the surgical arm. We actually didn't have any strokes in patients that have cortical strokes, that the rate was 30%. And all these data suggests that the EVA surgery is very promising to try these patients. So far, we have shown in a phase 1 and in a phase 2 that there is sufficient evidence to support a definitive randomized clinical trial of EVAs and ICAT. We have shown, and some other investigators have shown, that the revascularization after EVAs and indirect bypasses may occur between 15 and 30 days, which is a good timing, and that the rate of perioperative strokes is lower than in the direct bypasses. Because of that, we have been working with the NIH Stroke Network in the development of a phase 3 or pivotal RCS study that basically is in the plans, and that we hope that many institutions and many individuals that are seeing this presentation could be interested in participating. In general, it's going to be a multi-center randomized clinical trial. It has a seamless leading pivotal design in which we're going to have a leading phase that will be conducted when 86 patients are randomized in each arm, in which basically we're going to do a comparison with what we have done before to be sure that these rates of very low periprocedural stroke are maintained across the institutions, and that we can maintain that very important aspect of perioperative risk very low. This will determine a go, no-go phase. If it's a go, then we can move forward to continue enrolling in the 40 centers until we complete 516 patients, total randomizations with 258 in each arm. The seamless design allows us to include those initial patients, so we don't have to do 2 studies, but we can do it with 1. And these are basically some of the analysis proposed, in which we will be, of course, looking at the perioperative risk of a stroke, but also looking at the time, because we know that if anything, the advantage that EVAs may have over medical management is mainly in the long term, and the selection of patients will be focusing those patients that have hemodynamic components of a stroke, basically those individuals that have either borders on strokes or cortical strokes, in which the artery-to-artery embolism may have hemodynamic components. This should allows us to select the population of patients that is not being treated currently with medical management, and that can potentially benefit from surgery to improve the brain perfusion. This is a little bit of the structure with several committees for independent evaluations, following the usual structure of the stroke network. And I may click that credentialing committee because as it should be done in a clinical trial. We want everybody, of course, the patients to be safe, but everybody to do well. And we want the surgeons and the anesthesiologists of the institutions to be credentialed to do this. We have created a system to expedite that, but in essence, we want to show to be sure that the individuals that are going to be participating in the surgery can maintain safe rates of low complications in the perioperative period. The trial introduces also a new concept, that is to train and credential not only the surgeons, as it has been done in the past, but also the anesthesiologists, which I think play a very important role in the performance of this study. As I mentioned, the surgery is relatively simple, and our part can go very well, but we need really to work with anesthesiologists to be sure that all the hemodynamic factors are strictly controlled, that they're familiar with the nuances of cerebrovascular anesthesia, which are different than for other neurosurgical interventions. And by doing that, we can maintain low risk of perioperative strokes. We also will have independent evaluations for all the assessments. So it's not only me or other surgeons thinking that we did well. We have the tendency to do that. So it will be basically by independent assessors with blinding to the extent of what is possible and with objective criteria based on questionnaires, images, and not necessarily the only clinical evaluation that we do. And having said all this, I will be happy to answer questions that you may have. I hope this has shown you the logic of trying something different, of trying to do an interventional procedure that is less invasive than the surgery that the direct bypass entitles, and that potentially can have the advantage of helping a population of patients that have not received any significant improvement in their management for a long time. I think the logic of doing this is there, and it will be a great opportunity for the neurosurgical community to actually develop a procedure on a randomized clinical trial with sufficient evidence to be performed safely for these patients. So again, a pleasure to be here and happy to answer your questions.
Thank you so much, Professor. It's been a terrific talk, very useful for us. First of all, Dr. Montit has a comment or question. He's raising hands.
Dr. Gonzalez, it's great to have you here in Seattle, and we really appreciate your time. That was an amazing talk and really important. It's great to get enthusiasm back for bypass surgery. I had a couple of comments and then a question. Do you ever, or questions, do you ever change your mind to do a direct bypass? Often I'll keep vessel in continuity, and then if I see a really juicy middle cerebral, even for ICAD, I might do a direct if I think it can be done safely in one of those high-risk patients. So the first question is, do you ever switch gears and do a direct bypass in those patients? And the second question is one that I had to deal with this week, which was anaphylaxis to aspirin. And what is your antiplatelet regime in patients that are typically on Plavix preoperatively and then have some allergic reaction to aspirin therapy? Thanks.
Those are excellent questions, and the answer to the first one, the short answer is no, because we have been conducting these surgeries within the parameters of a clinical study, and because of that, we want to be consistent, and we want to not to have many modifications around the technique. And that brings me a very important point. When you look at the literature of comparison of direct and indirect bypass, particularly in patients with moyamoya, there are several studies that have been trying to follow a little bit of that artistic trend that we tend to have. That is that we see an artery, it looks so good that we think that the direct bypass is going to be better, and the voices in your head start telling you to do that one. However, the voices in the clinical trials that have tried direct bypass have shown no benefit. So because of that, we consent these patients to be part of a study. We have done every single patient under the structure of a research to collect their data. And because of that, we don't modify. One of the problems of the literature for moya that has been based on the opposite direction, that is the thought of many schools of trying to do a direct bypass if you can, and then if for some reason you see that the arteries are terrible, that the quality of this is not good, or a patient is to seek to switch it and do an indirect bypass that is lower risk. And several of the comparative trials between direct and indirect bypasses, that none of them have been randomized, but have used this real world approach of trying to do a direct bypass first, and if it doesn't work or is too, it seems that it's going to be a failure, then switch to indirect bypasses, that obviously you introduce bias against indirect bypass. So as a consequence of that, in the moya literature, many of the papers that have claimed some benefit for the direct bypass actually have that problem. That is that you really cannot tell, because you have been consistently selecting the bad patients for the indirect bypass. Because our purpose was clearly from the beginning to do the research, if we were going to be doing direct bypasses again, we will have to do something different than COS and ECIC that try very strongly to select well the patients and to do the best surgical that was possible. For that reason, we have not been doing it. Of course, it will be in the pivotal trial violation of the protocol, because what we want to test is the hypothesis that indirect bypasses can be better on their own without bringing the direct flow. So basically, I don't switch like that. I do still direct bypasses mainly for patients that have giant aneurysms, or for individuals that have tumors or things in which we may need to sacrifice a vessel. So in those instances, I still do the direct bypasses for those patients, and they are, of course, not part of this study that focuses only on intracranial atherosclerosis. Regarding the second question that is very important, is we have had few patients that have severe allergies to aspirin, and in those patients, we actually operate them on Plavix. One thing that I do is I get platelet aggregometry before, or even just a point of care P2Y12 assay to be sure that they are not ridiculously suppressed with the Plavix. And as long as they are within the usual parameters that we have for the use of stents for other circumstances, then I do the surgery on Plavix. One of the advantages of the EDAS is that if you're very meticulous with the hemostasis, you actually can control it. And fortunately, we haven't had higher risk of hemorrhages or hemorrhagic complications with those patients. The hemostasis is a little bit of an annoyance, because we have to be very careful to maintain an absolutely dry field. And I tend to not to let the blood pressure go too high, but to maintain it high enough that they're not having symptoms, but usually not above 160 after the operation, because that may be problematic. So I like to bring it down to very tight parameters, usually 130 to 160, 140 to 160, and maintaining the ICU like that.
That's great. Thanks for that. Some people have used IV Cangrelor, as a bridge. I've tried Plavix a handful of times and have been less enthusiastic about it than your experience. So something to look at. But I too was measuring the P2Y12, but there were some challenges with hemostasis for sure. But thanks.
Yes. And again, let me bring to your attention some of the recent publications that have been done more in the setting of, it's a little bit different, but kind of a general idea for patients that we end up doing angioplasties and stentings when we go to treat acute strokes, that sometimes we have those individuals that have an stenosis, tandem stenosis in the carotid, and then they come with acute stroke. We go and do a thrombectomy, and then we have a carotid that is occluded, and then we have to do something about that. And in many cases, we end up putting stents. I know it's a little bit different, but in those patients, there are several studies that have been recently published that show that of the options that we have, like using IV Cangrelor or the 3AB inhibitors, or actually loading with oral Plavix and aspirin, the risk of hemorrhage was slightly lower with the aspirin and Plavix than with the IV medications. But it's a different animal, because of course you're putting on a stent in a big vessel, so the flow is much better. But at least from the side of the risk of hemorrhage, that makes me feel a little bit better. And some of my residents don't say that we don't do meticulous hemostasis, we do ridiculous hemostasis because it takes a good amount of the time. So that has helped us to prevent those complications. But I get you. Fortunately, aspirin anaphylaxis is not that common, so we don't have to face this too often.
Okay, Professor, one question regarding Sampris. So the maximal medical management, I mean, our gold standard is Sampris, right? So how do you compare the actual medical management to Sampris? Because Sampris has been like 11 or 12 years ago. And do you think there has been any significant modification of that?
That's a very good question, and the short answer again is not much. There is some new studies that are going on. Captiva is trying to see the risk of and benefit of anticoagulation instead of antiplatelets for the management of patients with intracranial atherosclerosis. We still have actually the same goal that Sampris had of having an LDL-C of less than 70, of having a systolic blood pressure of less than 140, of having an active lifestyle, of controlling the hemoglobin A1C to a level below 6%. The only clarification is that at some point after Sampris, we didn't know for how long you needed to take the patients or maintain the patients with dual antiplatelets. In the Sampris, it was done for 90 days. And kind of the recommendations, the current recommendations of the American Heart Association and the American Academy of Neurology is to not necessarily prolong beyond 90 days the dual antiplatelets, which is actually the Sampris protocol. Some patients that may have cardiac conditions that require Plavix then can have the treatment for a longer time. But in reality, the medical management has not changed much since Sampris. There is new medications like the PCSK9 inhibitors that have been very effective in the management of cholesterol, and in large trials that were done for general cardiovascular risk have shown also a reduction in the risk of a stroke, but there is no clinical trials that have compared them specifically for intracranial atherosclerosis with the use of statins, for example. So those medications are very useful in patients that cannot tolerate the statins. And for the ERSIS trial, we actually consider that if there is a change in the medical management in the future that comes showing that there is a benefit, then that should be introduced to both arms, the medical arm and the surgical arm. But for now, you look at the guidelines of the American Heart Association or the recent statement for the treatment of patients with intracranial atherosclerosis of the American Academy of Neurology. Basically, we're following the same criteria that was found in Sampris.
Okay, and Sampris didn't have any kind of platelet inhibition test. Do you think that's going to change anything?
Yeah, that's also a very important question. That's interesting because, yes, I think it's important to add that even though we don't have complete evidence of what is the level that we want, I mentioned the P2Y12 and the platelet aggregometry as a guideline, but we kind of know that these tests help us to identify people who will fail medical management because they're not responders to Plavix, and I think identifying that group of patients is important. For the ERSIS trial, we're including to have those point of care evaluations to be sure that if a patient actually doesn't respond to Plavix, then we don't use Plavix on them. The failure of response to aspirin is more strange, it's rare. It's usually associated with other medications that may be interacting, but not really to an innate condition of the patient that makes them fail the treatment with aspirin. But I think identifying patients that are not responders to Plavix is important. That has not been generally established. Captiva is introducing some of these in his arm, and actually one of the new things that we're going to be doing for the ERSIS trial is to include that to be sure that there is not a disproportionate number of patients that are non-responder in one of the arms, and that is the reason why they are failing.
Okay, Professor, you published a post-hoc analysis of the ERSIAS-2, which says that the border zone strokes, I mean, the patients with border zone benefit more than focal strokes. Why do you think that is? Because it's, I mean, it's related to hypoperfusion and not emboli, or?
Yes, and more than focal stroke is patients that have lenticular striated strokes. because for patients, remembering the first slides that I show of the multiple mechanisms of stroke, when you have intracranial atherosclerosis, some of those patients may just get lenticular striatal strokes with basal ganglia strokes. For those patients, most likely the medical management is the best thing that you can do. The component of hypoperfusion is very limited. For patients that have border zone strokes or patients that have artery-to-artery embolisms, for those patients, the hemodynamic component is very important. The medical management that we have correct the other factors, correct to a good extent, the inflammation of the plaque, the formation of clots, the in situ thrombosis are addressed by using antiplatelets, statins, and so on. But those factors cannot, those medications cannot modify low perfusion. That's why in the sub-risk population, the highest rate of stroke was in the border zone, because those were the patients that didn't have any improvement of the perfusion. Unfortunately, they didn't improve also with the angioplasty and stent, in part because of the rate of complications. So while it was like 37% for the patients in the medical arm, it was close to 40% the risk of a stroke after angioplasty and stenting. So that's why I think the population with hypoperfusion are the ones at higher risk, and those are the ones who can benefit from a revascularization procedure.
Okay, Professor, how do you compare EDAs to EDAMs, for example? Why don't you use the muscle that is so rich in vasculars?
Yes, that is also an excellent question. And there are groups around the world, particularly for the treatment of moyamoya, that prefer to do the EMASs. There are a couple of things that we have early in our experience when we were trying to use these in patients with atherosclerosis that we have learned from patients with moyamoya that limit us in the use of the EMAS. But this is anecdotal, and I cannot say that there is a significant comparison showing that one is better than the other one. But let me share with you the logic of why we don't use much of the EMASs. The main reason was that we have actually a slightly higher rate of seizures with patients that we use the muscle to do revascularization. We think that part of the depolarization of the muscle may have caused that, and it was transmitted to the brain. So we have almost the double of number of patients with having seizures, and they would develop seizures while they were eating, just by chewing, I imagine because of contractions of the muscle causing some form of disarrangement. The second thing is that there is a cosmetic factor to that, and some patients didn't like the atrophy of the muscle and the asymmetry that caused in their head. That one is more in patients with young patients with moyamoya that it may become a little bit more notorious, but those were the main two reasons. The final reason is kind of a methodological reason, is that we wanted to create a technique that we could try to standardize, to test one technique, not many techniques, because that's when we run into trouble in surgical trials. Surgery, and it's part of the beauty of what we do, has this artistic portion of it. Yes, we are technicians in a way, but we are also a little bit of artists. We find the tissues and we handle them differently, and the patients are differently, and surgeons have different styles. But that makes it difficult to do science for clinical trials for surgical treatments, because those variations, it's difficult to tell when they're going to start introducing modifications and biases. So we try to use for this trial, and we will encourage the people who participate in the study to adhere to an STA, middle artery preservation, dural use, to test really one technique. If it doesn't work, then we can go back to the drawing board and see if there's only other one that works. But so far, the one that we have advanced is this EDAS technique. So just for methodological reasons.
Okay, Professor, do you believe in maybe doing EDAS prophylactically, like before failure? Is there any?
Yes, we haven't done that because surgical interventions carry some risk, and I prefer to offer them to patients that are already at high risk of a stroke. If not, I would prefer to treat them with the standard medical management. I think is easy to advance a new technique for difficult cases. I think we need to be first being able to show that there is some benefit in that population. It would be more difficult to do a clinical trial as a prophylaxis. because of the imposed risk of surgery and the uncertainties that we still have. That's why we have to do a clinical trial to resolve those uncertainties. So maybe in the future, in the case of Moyamoya, there's also a lot of discussion about that, depending on the populations. And I think Moyamoya is a different condition. Moyamoya is a progressive condition. More than 40% of patients with Moyamoya, even if they are not symptomatic, they will develop symptoms at some point. So in the Moyamoya patients, I think it is reasonable to consider to do surgical revascularizations before they have symptoms. Again, there is not complete agreement on that. Many people will prefer not to do it. There is some evidence from the recent trials in Japan that may even benefit the risk of hemorrhage, even though it was not statistically significant, but it was nominally better. But for the patients with atherosclerosis, I think these are patients at high risk. Their surgeries and the cardiac condition and the anesthesia management is complex, and it will be difficult to justify to do it as a prophylaxis for that population. For patients with IDAS, a different thing, and I think it's reasonable because of the nature of Moyamoya that is going to end up having very high risk of strokes. And the perioperative risk, which is lower, they're usually younger patients.
Okay.
Thanks, Professor Gonzalez. I have this question. How would you define medical failure, failure of medical management that would indicate you to do the EDAS? Is like strokes or TIA under aspirin alone is you defined as a failure, or you wait until they get symptomatic under dual antiplatelets?
Yes, that is also a very good question. For the clinical trial that we're planning, in which we hope many of you guys can participate, the patients will be randomized if they have any condition that is a TIA or a stroke in a territory of the carotid artery or the MCA. And even if they have not received medical management, they will be randomized either to medical management plus surgery or medical management alone. So far, we have been selecting only patients that have optimized medical management. That means they have at least one antiplatelet agent, at least a statin, and at least some form of blood pressure management, and that still have TIAs or a stroke. However, for the randomized clinical trial, we are going to be including patients up front. When they present with the symptoms, they can be randomized to medical management with surgery or medical management alone. There's a little bit of a difference between those two things. So far, we have been picking those that are at least in an optimized form of management that have failed.
Okay, Professor, do you have experience with NOVA for a flow study maybe to predict which patients are going to respond better to EDAS?
Yes. So the measurements of flow, that is something that Fadi Charbel and the group from the University of Illinois have been advancing, is very interesting and very good. We try to do some studies. It's difficult sometimes in the EDAS unless you go and tell the technicians where is the superficial temporal artery to measure the bypass. So it takes a little bit of time. Fadi and his group have shown that the maintenance of the flow is a good predictor. We have been doing more of the perfusion evaluations that at the end is kind of the end marker. And we prefer to use that one as a substitute from the flow itself. We measure the flow and we noticed that around 3 weeks, there was increases in the flow in the superficial temporal artery, but it was in a very limited number of cases. That's why we didn't publish it. For direct bypasses, as you know, when they do a direct bypass alone, it has been shown that around 6 months, actually, the direct bypass may not work much in many instances. And then kind of the flow gets to be formed by indirect bypasses that get to be spontaneously formed. And that's why there is a good and large, very logical school of thought that maybe doing combinations of bypasses for Moyamoya disease is a good idea. For patients with intracranial atherosclerosis, we have not used the ANOVA.
Okay, maybe the last question, Professor. Do you have any? Do we have any way to measure how hungry the brain is for vessel and the angiogenesis of this specific brain, like any kind of CSF study for angiogenetic factors?
Yes, so far I think we use a clinical criteria, that is the fact that the patient is having either borders on strokes or TIAs or strokes usually indicates there is a failure and that there is not enough collaterals. Which levels and which markers can be seen in the blood is a little bit more complex. And we have published also a couple of papers in Nature Scientific Reviews and in the International Journal of Stroke, where we measure actually the circulating angiogenic factors of patients before and after the interventions. And we have interesting findings that hopefully part of the experimental arms or experimental goals of the ARSS trial is to collect blood from these samples to really confirm these findings that we have. But what we have found so far is this, which is quite interesting. It seems that patients that have intracranial stenosis that is due to moya have actually circulating factors that are proangiogenic. They have higher levels of vascular endothelial growth factor 165A, which is a form of proangiogenic factors. While patients with intracranial atherosclerosis that have failed medical management have higher levels of anti-angiogenic factors, particularly endostatin, and some of the forms of angiostatin. So we think that somehow the patients that fail medical management have an innate inability to produce vessels on their own. That could be a problem for the EVAS trial, admittedly, because if there is not enough of these factors, it may block the formation of vessels. On the other hand, clinically, we have seen, and in images, that we form vessels anyway from the vascular territories that we use as donors. But we want to see this because this can become an interesting modifiable factor in the future for the treatment of patients with a stroke. If there are really profiles of anti-angiogenesis and angiogenesis that influence the ability of somebody to develop their collaterals, then potentially there could be pathways to treat that in the future and modify the response. In my lab, we are working in some animal models to see if we can actually stimulate the growth of vessels. So we have, in one side, the clinical advancement that we have done, and hopefully we can test that theory. If it fails, then we have the alternative of studying in the future the possibility of modifying angiogenesis as a potential tool to improve the revascularization in these patients.
Okay, Professor, one last question from the audience. What is the value of MRI perfusion in the pre-op evaluation? You're only with clinical manifestations, or you use the complementary? I mean, what if there is some?
Yes, for the phase 2 study, we included MRI studies. I didn't put that in the slides because all the patients that are included have hypoperfusion in the MRI. So, and as you can imagine, if a patient presents with borders on a stroke or with TIA despite medical management that correspond to likely hypoperfusion, they have hypoperfusion in the MRI. We do this study to confirm that it is hypoperfusion. We don't include patients that have basal ganglia strokes because that would be not necessarily very useful to do the revascularization. So we have a selection already of patients that if they are having symptoms and they don't have lenticular striated or basal ganglia stroke is because they're failing. And that gets to be confirmed uniformly in the perfusion studies. I don't think I have one patient that we include that had symptoms and was having a normal perfusion. So it's not a mandatory criteria for the clinical trial that we're putting together because clinically it's sufficient, but I think it's recommended that we do that because it also allows us to compare how the things will go. So we are going to be sponsoring some of these images to compare and see if, as with Moya has been shown, if we can use perfusion studies to monitor the progression of these patients, which, as I show in several of the slides, have been a very important tool to determine that early revascularization occurs within 15 days or so of an indirect bypass. So I think it's a very useful tool. Still, what counts the most is the clinical presentation of the patient.
Okay, Professor, thank you so much. It's been a great talk. We learned a lot. So thanks, and I hope we can have you afterwards in some other occasion.
Thanks. Thank you. And I hope to work with all of you and many of the audience in this very interesting project. Is as I was saying before we start the video, vascular surgery has changed a lot over time. We do a good amount of the work now endovascularly. Those techniques are very powerful, but there is something very beautiful about surgeries, and it would be wonderful to be able to test in a very strict, rigorous form a surgical technique that has shown so much promise so far, and do it for a population of patients that really need it and for which we don't have any other alternatives. Maintaining our skills to do bypasses is very important. This is a very valuable tool, and modifying those to even treat patients that are so sick could be a very useful portion of our training as neurosurgeon and our practice to maintain alive techniques that have been developed over the years, but that have been difficult to study. So it's a pleasure to be here. Thank you again for the invitation, and I hope to see many of you soon.
Thanks, Nestor. We'd love to be part of your trial. It was a great talk.
Thank you, Stephen. A pleasure to be here.
Bye.
Bye, Professor. Thanks so much.